Good afternoon, everyone.
Welcome, and thank you for joining the Clinical and Translational Science Collaborative of Northern Ohio for our first Black Maternal Health Equity Summit. Inspired by Black Mamas Matter Alliance's Black Maternal Health Week that started in 2018 and takes place yearly between April 11th and 17th, we are fortunate to be among one of many organizations that are not only acknowledging the Black maternal health crisis, but also taking responsibility for our role in helping to develop and implement solutions. The CTSC is a collaborative among Case Western Reserve University and the Cleveland Clinic, Metro Health, University Hospitals, the VA Northeast Ohio Health System, Northeast Ohio Medical University, and the University of Toledo. We aspire to be a catalyst for high-quality clinical and translational science and transformative research to positively impact the health of those in Northern Ohio and beyond. With world-class healthcare and academic institutions at our fingertips, we are juxtaposed by some of the worst health outcomes in our nation, notably for Black maternal health. So what will we do about it? From the CTSC's perspective, we will leverage translation, the process of turning observations in the laboratory, clinic, and community into interventions that will improve the health of individuals and the public. We will fund research in the later stages of the translational science spectrum, where clinical implementation and public health are central to improving community health. We will focus on unmet needs, use bold and rigorous approaches, ignite boundary-crossing partnerships, and encourage creativity and innovation, principles of translational science, in our approaches to advancing health equity through research. So here's what you can expect today. We'll have our keynote presentation and introduction, Q&A, voices of mothers, and we'll hear from local mothers, very excited about that. Research and policy highlights, challenges and opportunities, impact rounds, and then closing remarks. Thank you to our 25 sponsors. We could not have done this without you. This was really a dream, and to see all of you in this room today, this room is full. Look around, caring about Black maternal health equity. Our sponsors made this event possible and to be executed in a way that fostered accessibility and inclusion. The 25 logos that you see on this slide and in your program are more than graphics for brand recognition. Their investment in this summit illustrates their commitment to advancing Black maternal health equity. And without further ado, I'd like to have Dr. Rachel Dudley from the University of Toledo come up to the stage to introduce our keynote.
Good afternoon, everybody. Thank you so much to Cleveland State University for hosting us, and to the organizers of this event, especially folks I'm seated with up here, especially Jaleese Thomas, Juris Doctorate, don't forget it, degree holder, and Director of Research and Health Equity for Case Western University's Clinical and Translational Science Collaborative. I'm also bringing greetings from Dr. Dilip Das and Malika Bell, Vice President and Director, respectively, of Diversity, Equity, and Inclusion at the University of Toledo, and greetings also from my colleagues in the Department of Women's and Gender Studies and Africana Studies at U Toledo as well. I am so grateful and honored to be here with you today to introduce our keynote speaker, Dr. Deirdre Cooper Owens. She is an award-winning professor of history, jointly appointed with the Africana Studies Institute at the University of Connecticut. Dr. Cooper Owens is, of course, the trailblazing author of Medical Bondage, Race, Gender, and the Origins of American Gynecology. She has served as a fellow for the American College of Obstetricians and Gynecologists, and she was awarded the Darlene Clark Hine Prize by the Organization of American Historians. Professor Clark Hine, of course, is a historian of the African American experience who helped found the field of Black women's history. It's clear that Dr. Cooper Owens' scholarship has raised U.S. consciousness around the exploitation of 19th century African American enslaved women in the professionalization of modern gynecology as a discrete field of medical practice. Her path-breaking work emphasizes the contradictions in 19th century scientific racism, used, of course, to justify the violence of slavery, and her work rightfully places the enslaved women at the center of the narrative. As both non-consensual experimental patients, as well as skilled, trained nurses in the first women's hospital in the country, a backyard slave hospital owned by Dr. James Marion Sims. Sims was one of several Southern doctors whose exploitation of enslaved women helped catapult them into international prominence, especially Sims, who became known as the father of modern gynecology by the time of his death in 1883. We know so few of these women's names, but three names we do know: Anarcha, Lucy, and Betsy, who have become powerful and symbolic Black ancestral figures. As someone who researches and publishes in this area, who had just finished my dissertation, James Marion Sims and the Legacies of Enslaved Women in Women's Gender and Sexuality Studies at Emory in Atlanta, I can speak directly to the seismic shift Dr. Cooper Owens' book created in this area of scholarship. It has certainly influenced my own thinking, and Dr. Cooper Owens' impact is evident in my forthcoming first book, which explores the roles of Black feminism, art, grassroots activism, and cultural memory in relation to the lives and legacies of the foremothers of American gynecology. The impact of Dr. Cooper Owens' work has helped to shift the academic, medical, cultural, and political landscapes of the United States and beyond, with implications in scholarly research, in activism, in grassroots advocacy, and in health professions training. To consider the international impact of Dr. Cooper Owens' work, it's important to note that medical bondage has been translated into Korean and will soon be translated into Brazilian Portuguese. Since the publication of Medical Bondage, yes, in 2017, since the publication of Medical Bondage in 2017, Dr. Cooper Owens has been writing in both scholarly and popular venues and speaking all across the nation as an advocate within the reproductive justice and birthing justice space, addressing issues with the continuing legacy of slavery in relation to the Black infant and maternal health crisis in the US. We, of course, in this room and live streaming, know all too well that US maternal mortality rates are 4 times those of non-Hispanic white women, which are rates considered by public health practitioners to be the worst in the industrialized nation, among industrialized nations. What's most noteworthy, perhaps, is looking around here, all of the communities that this work brings together and the stakeholders that Dr. Cooper Owens' work brings together to help dismantle this public health crisis. And our presence here today at the first regional Black Maternal Health Equity Summit in the state of Ohio is a testament to that. Without further ado, please join me in welcoming our keynote speaker to the podium, Dr. Deirdre Cooper Owens.
Thank you, Dr. Cooper Owens. So if we have any questions from the audience, someone will run a mic to you. So if you could just raise your hand.
Oh yeah, it's very easy. Historian at DeirdreCooperOwens.com. CooperOwens.com, and my name is spelled in the book, and they even spelled it right this time. So you're welcome.
Thank you. Tennille Coss with the Legal Aid Society of Cleveland. Thank you so much for the historical perspective. Can you talk a little bit about some of the social determinants of health on our Black mothers specifically and how that is impacting maternal health?
Oh my goodness, that's a great question. So I think you all heard since she had the mic. The social determinants of health are, the very things that we kind of know of, right? Economics, whether one lives in areas where there's a lack of infrastructure to heal people. So you might have in rural areas clinics as opposed to brick and mortar hospitals. Whether there's transportation or not. I often use my home county in South Carolina. The maternity ward was closed in the hospital in 1990. That's when I graduated high school. I'm 51. I'll be 52 on the 17th. There has never been a maternity ward built. There is no public transportation. So you would have to travel and find it on your own to get to the next county to be able to have a child. That is quite normal for a lot of rural spaces. The environment, there are social determinants of whether one is partnered or not, whether you have to do it all by yourself and you don't have community support. I could go, on and on. So the social determinants are important. And for me, that's the importance of reproductive justice, because it's so intersectional in terms of the framework of reproductive justice that they've always amplified access, which is a very different conversation than choice, right? That mainstream white feminists had around abortion. And so I think a part of that is to speak to the holistic person. So all of those things that I named are important to emphasize, but also recognizing that the stats for Black women and birthing people, none of the factors that typically have been protective for other groups of women, meaning economic status, educational attainment, partnerships, none of that matters for Black women, which is, that is strange. So all of the things that I represent on this stage, glory, hallelujah, this book finally made me middle class, right? That's about, because let me tell you what, I was not before this book. I've always had lots of jobs, right? So this book kind of changed my life, but I'm partnered. I've been married for a long time. I have a PhD. I earn, a middle class salary. None of that protects me. And in fact, out of Black women in this country, I am the one who's most at risk for having complications. So once again, the social determinants are important, but it doesn't seem to have the same effect for protecting us when we have those markers of success. So that's something else, that I think we really need to concentrate on. Why is that happening?
Hi, Dr. Owens.
Hi.
So glad to have you here today. I'm a Black archivist and artist, and I've jumped off, fully into generative AI just to immerse myself in it. How do you see that helping with what you do in teaching and the bias that you find in these medical and nursing students?
Oh my goodness. I think that would be wonderful to be able to do a kind of, so I'm not a digital humanist, but in digital humanities in my field, I think it would be wonderful because it would be, I think, a more accessible way to grab the attention, particularly of students, but to be able to walk them through the process. And so it's being done. I haven't done it because I'm not a digital humanist. I'm kind of old school. I write articles and books and give talks. But I can see it certainly opening up an avenue, particularly for the ways that people even learn about the bodies. I was just I told you I travel so much. I think this was Kentucky, in Lexington, Kentucky. No, I'm sorry, Providence College in Rhode Island. And Providence has a space for their health allied students where they're literally using that same kind of AI technology to erase some of the unethical practices. So they have these bodies. It's weird. So the only thing I can think of it is like those little sex dolls that those men buy and name them and marry them and stuff. I'm serious. That's how they look. But they just have clothes on, right? And so, but they have pulse, like a pulse. So they're touch zones for pulse. The skin feels almost human-like. And so it they're trying to help erase some of the bias that happens, with patient, doctor, nurses, those kinds of exchanges. So I see it opening up a really wonderful way of learning. Yeah, you're welcome. This.
Hi, I'm Crystal Boyd Funderburg, and I'm an occupational therapist as well as a doctoral student getting my doctorate in health sciences. So I was listening to you about the learning modules that you have for medical students in nursing, but would they be able to apply to other healthcare professionals?
I sorry, dropped my thumb drive. I would hope so. I mean, if they ask me, yes. But what I would really hope is that in these schools, the courses that I teach in the humanities would not be considered electives in the schools for health and allied sciences. So it really is up to the students to go to deans, go to professors, go to administrators and say, look at the stats. It is clear that we're graduating people who continue to practice these kinds of harmful, they're practicing out their harmful beliefs about Black people or poor people or, fat people, disabled people. And so we like for these courses to be, a part of the general curriculum. I'm not, I'm only going to be asked for people who see my work as relevant to theirs. So I don't necessarily know, right, if an occupational therapist is going to see my work as relevant. It tends to be people who are interested in reproductive health for women. But it's something that you can do as a student. Just get a group of students, come armed with the research. I mean, that's why you're getting your doctorate. So you come armed with the research to show the harmful practices. Make it very local, right? What's happening in the community where the school is. I often share with hospitals, who's on your board? I understand we have to have check writers, but what about people in the community? If you don't have somebody from the community where the hospital or the clinic is placed on the board, is it really a democratic space in terms of shared governance? So those are also things, right, that you can consider impressing upon some of the administrators. I think that's important.
Hi, Dr. Cooper. So I work in perinatal mental health with Black families. So a lot of the information you gave today was very helpful. I loved how you said that when you incorporate Black physicians and postpartum specialists into the equation, like the numbers of Black maternal mortality go down. How would you address misogyny and bias within Black communities when they're treating other Black women but still have bias and racism and misogyny of their own?
Ooh, that's another one. I don't know. That is hard because there are just some people who are not going to be interested in what I say because of what I represent. Right. There's I saw, I look at a lot of social media and somebody had a quote from Mace, the former rapper, who says he was responding about this woman being considered to coach an NBA team, a male NBA team. And he was like, I just think it's unnatural that women lead, should lead. So this is an inside joke. When I went to Clark Atlanta, back when I was young and slim, he tried to holler at me. I'm glad I dissed him. And so I was smart. But I mean, how does one change that? The thing is, if that person doesn't want to be changed, right? It's no matter, I remember I would give these talks in the beginning and I would give all the statistics and I would always, I promise you, always have a white woman come to me and say, well, I have 5 children. Doctors don't listen to any women. But they would never say it aloud. They'd always come to me like at the lectern afterwards. And so that's why I started finally putting in the Kara Hoffman piece. That's the petty part of me. Now what? Now what? Because the stats show, right, that even when if your choice is to be a misogynist or a racist or a classist, that's what you're going to be, no matter what we say. The only thing is we have to come up with some punitive measures to be able to make sure that those people don't leverage the same kind of power, because you might not change their minds. There are students who I know from the moment I walk into the class do not like me, not because I did anything to them. They don't like what I represent, and they let it be known. But at the end of the day, right, either you're going to do the work and earn a good grade or you're not. And whatever you think about me personally, I don't have anything to do with that. But I know that I'm in a space at least that protects me in that way. So you have to create a space that protects people from the misogynist or the racist or the, whomever else. But I know those things exist. I mean, we could talk about the ways that sometimes, people who look like us, who are born in different spaces, have a lot of animus towards African Americans, and then vice versa, right? I mean, those are real issues. And so we just have to, once again, I think, have something punitive that sticks, that lets them know, you're going with your racism and your sexism. I got something for you. And it actually means something, right? And so you have to be able to create that in your space because you know how those particular people move.
Hi, my name is Nadia. I'm a nurse midwife. Thank you so much for your
Thank
work
you.
and your scholarship. I wanted to ask if you could share anything more that you've learned that is particularly protective for Black folks in the perinatal time, since so many factors that we know work for others just don't seem to work in our
Yeah.
community.
Community is important. I think community. Oftentimes letting people, so I'm old school in terms of recognizing the importance of institution building, but also being affiliated with institutions. And so I say that because I'd say it was probably around 10, 15 years ago, there was kind of the rise of what I call the armchair activists. And so they did everything online and solo. And a lot of, I think, the potential for what could have been was squandered because there wasn't an alliance with a larger group of like-minded people. So that's why I never say I'm an activist. I'm an advocate, right? Because I don't want to speak on behalf of the University of Connecticut, right? Because the University of Connecticut might not be aligned with what I would want to do as an activist. So that's why I would say I advocate on behalf of certain groups or causes. So what I think is you need to be aligned with people of a like mind and recognize that there's power in numbers, and also lean on the strengths. So if you know that there's someone really good with public policy, there's someone really good with, being in spaces where decisions are being made, try to assemble that. If you don't have that available, I think it's about letting these doctors know that you're going to advocate for yourself, and that you also know how to report. You notice I keep saying punitive. I'm big on that because as a historian, the only time this country has ever made changes that have been democratic have been because people have either engaged in battles and wars or the threat of. It's not because somebody who owned a slave suddenly got a religious awakening. It was because the Civil War happened. The Civil Rights Movement, it was the threat of someone like Malcolm X and the Black nationalists that changed things, not because people had a change of heart. And so for me, it really is how, once again, I go back to the punitive. How do you make sure that people are going to be held accountable for the really harmful things and violent things that they are doing to our community? There should be no hospital in a community that has double-digit maternal morbidity rates. And yet they are allowed to exist and get tax breaks and all of those kinds of things, right? So that's what I say. Gather up the numbers, the collective numbers. And I mean, look at this space here. You have a lot of like-minded people here. Gather up those numbers and, maybe I saw that there was something on the program about like information something where people are exchanging information. So maybe someone who's a midwife practitioner can meet up with you and then somebody else who, that's how it starts. One more, yep.
Thank you
Yes.
very much.
You're welcome.
For being here with us and all that you have and continue to do.
Thank you.
What part, if any, does insurance play in all of this?
Don't get me to talk about insurance. I went through IVF twice. I didn't cry about not getting pregnant. I cried about insurance, and that's real. It plays every part. Let's go back to, and I'll just harken back to C-sections. What is the investment for the doctor? Does the doctor really want to perform surgery when it might be easier to have a vaginal birth? Or does the hospital impress upon the physicians why it's so important to have C-sections? Insurance is more expensive. And yeah, so that's it's a wonderful question. It also shows the intersectionality of these oppressive systems, right? That when we talk about a medical industrial complex, it's not just, sometimes let's take the people out. It's what the structure represents. And insurance is a part of that. Big pharma is a part of that. That's why it's called a complex, right? It's a network of oppressive systems that are interlocked to often not provide the kind of healing care that we need, because the doctors are not making the decisions. The insurance decides if the doctor's decision is a valid one or not, right? And that is the problem. I'm like, wait, when did they become physicians? They're insurance people. Thank you for that.
Hi, my name is Dr. Latia Phillips-Bay, and I am also a social worker. I'm over here who advocates for.
We were all looking over here.
Right here.
Yes.
I'm Dr. Latia Phillips-Bay, and I am also a social worker who advocates for trauma-informed care of women, the empowerment and support of women. I am the CEO of the Women's Village, a village of support. And so apparently there's an apparent gap and what we are discussing today. Mm-hmm. And this is such a beautiful forum, summit. Mm-hmm. But my question is, what happens when this is over and everyone goes home and back to their normal routines? Where is the village? Where are the collaborative efforts to bring these numbers down, these percentages down in our communities, right? In the brown communities that have the highest percentages. Where is the assistance, the help? Mm-hmm. When do we stand strong on our squares? Mm-hmm. Titles don't mean anything if we are not truly advocating or doing the actual work, the holistic work, the spiritual work. It has to be holistic. Yeah. So that is just something to ponder. Mm-hmm. I thank you for bringing this. I thank you for your wisdom. Mm-hmm. Thank you.
Thank you.
Thank you.
Hi, I'm
Hello.
Dr. Linda, good morning and afternoon. I'm Dr. Linda Bradley. I'm an obstetrician, gynecologist at the Cleveland Clinic and a native Clevelander. I wrote a few points about the maternal mortality issue. My current aunt, who's 89, when she was born, her mother died in childbirth. When I had my first child, I was an M&M case, maternal morbidity, luckily not a mortality. So the issue of education is important, but we also have to remember that silence kills. Mm-hmm. Silence kills. And that we have to sort of stand on the shoulders to ask where we're going to go. We have to have a strong sisterhood within our community. Mm-hmm. We need to know about adverse childhood outcomes. We also have to look at what we're doing at the Cleveland Clinic. I'm very proud of the work that we're doing as it relates to Black women, brown women, and underserved women. We speak about, we have statements about patient rights, but we actually believe in it. Patients are given information. We have eminent grounds to discuss, was the complication due? You didn't give an antibiotic, they didn't get their belly washed long enough, but did race, ethnicity, all those kinds of things make a difference. So I think, again, the issue of speaking up makes a difference. Our hospital is making strides. We're not perfect, but what I like is that in the past, how I grew up as an intern resident and early physician, African-American physician, we could never talk about this. So the silent part, at least at most hospitals, I do want to make a very strong correction that it is happening. It's happening within our doors, and I'm very proud of it. I also think that younger people are taking the onus to speak up and ask their professors about some of the things that they hear, see, or not being done. I think we as women Finally, we have to take care of our own health. Do not wait for the health system to do everything. Exercise, eat well, food is health, mental health is important. Getting everyone involved is so important. We cannot do this alone. And the African proverb that says, if you want to go fast, go alone. If you want to go far, go together. So my thing is that we as Black women and brown women and all women, we have to help each other. We are our sister's keeper. Doctors are doing what we can, but enter pregnancy as healthy as you can be, and whatever that means for you. Go to the visits, bring someone with you, partner, have questions, read about your health, have a doula, talk to your physician. To me, these are all issues of partnership. My work right now, and I'm not retired, so I don't want any rumors passing here, but my work is not done. It will not be done until I see equity across all of obstetrics and gynecology. And so we would ask all of you, where do we go from here? It's a sunny day. Continue to have a conversation. When it's raining, have a conversation. If you see a mother that looks depressed, have a conversation with her, find out some of the resources. Encourage breastfeeding. Breast is best if they can do it. Things that we have gotten away from, I just see from my own family, we're just pushing off things, and we have to have ownership of our health. Do not wait entirely for the healthcare system. Do what you can for yourself, for your sisters, and for our community. And we are our sisters' keepers. That's what I would say. Thank you.
Amen. Namaste. All right. And Ashe.
Thank you, everyone, for your questions and comments and inspiration.